I would like to talk about a concept and a history of periodontal treatment. For instance, it has been regarded as a degenerative disease until the late 1800s. Then it was thought as one of the systemic diseases until bacteria were found. After that, there came many discoveries, including infections and immunity risk factors. Treatment theory has also changed from non-surgery in the 1940s to 1950s to excision treatment to regenerative treatment in the 1900s. For bacteriological diagnostic technique, culture technique was invented. Then detections of enzyme, immune systems, and DNA. DNA methods also changed from probing to real-time PCR amplification. Many changes have been seen along the way. What I learned from the history is that we need to pin down a cause before starting treatment. This is a 19-year-old patient who had aggressive periodontitis, which is called an extensive juvenile periodontitis a long time ago. There is a pocket of 10 millimeter or more in depth in the maxillary anterior tooth, which is the cause of the aggressive periodontitis or juvenile periodontitis. As destruction by bacteria is more powerful than power factor, left bones without hypha at bifurcation areas is a characteristic. It is a big difference between aggressive periodontitis and adult periodontitis or chronic periodontitis. Preoperative bacteria test indicated PG level is 10%, which is above the normal value, 0.5%. What we did was use tetracycline for a month. Followed by adjunctive full mouth treatment to remove periodontal bacteria firstly as a basic periodontal treatment, which aimed to remove bacterial factor of the disease. This was performed on the first visit. Since the full mouth disinfection was already performed, we provided brushing training, occlusion adjustment, and scaling root planing that required only 1 day. All were done at a fast pace, so 2.5 months after the first visit, it showed an improvement like this. After the completion of the basic periodontal treatment, we performed a therapy to remove the cause further, repaired collapsed gingiva, and provided regenerative therapy. We have also removed the plaque using a microscope. 10 years have passed since then, and we still conduct a microbial test once a year or so. Been confirmed showing good maintenance results. Since regenerative therapy for a full month was performed, bones are in good condition as well. Using the same concept, the next case is a 41-year-old patient with aggressive periodontal. Implants are included this time. None of the teeth were pulled out by a dentist. They fell off naturally. We performed a bacterial test as we did earlier. Now that we can evaluate antibody titers, we see AA and PG are significantly high. However, antibody titers of AA did not increase. In short, the antigen are not recognized by the human body. This is a major cause of aggressive periodontal disease. We took 1 month to disinfect inside of the patient's mouth using amoxicillin and metronidazole. Then we performed sinus lift regenerative treatment, extracted a tooth impossible to keep, etc. 7 years after the surgery now, we perform a bacterial test each year and evaluate antibody titers as well. As you know, antibody titers decreases if its cause is removed. Though there were not antibodies against AA from the beginning, but other antibodies such as PG, titer levels became lower. Bacterial counts, which were detected at first visit, did decrease. As shown, a comprehensive approach such as prosthesis, including TMJ, is important and necessary, but I strongly recognize the importance of conducting a microbial test and antibacterial therapy if necessary for the treatment of periodontal disease, an infectious disease, at the very first stage of treatment. What is a history for the antibacterial therapy, by the way? This illustration shows the Battle of Sekigahara, the Opium War in 1847. This one in 1904 is the battleship Mikasa. Some of you from Kanagawa Dental University are well aware of this, I bet. This is the flagship fought in the Russo-Japanese War against the Baltic Fleet. The Wall Street crash, the Korean War, how antibacterial therapies have changed during these times. Before the year 1600 or so, people knew that injuries can be cured by blowing a sharp blast of high alcohol on a wound through experiences by samurais. This is, in short, a disinfection using alcohol. To purify something with alcohol comes from this. In mid-1800, this is the era of a sudden rise of bacteriology. Childbed fever, fever after delivery. Around this time, university hospitals centering on Boston universities have first started setting up a gynecology department. Initially, there was no concept of preoperative disinfection. There had been no delivery cases at a gynecology department so far, since there was no such thing. It was the epoch-making event. Dr. Semmelweis applied bleaching powder to his hands to remove smell in the beginning. This act is equivalent to that of disinfection with sodium hypochlorite. Dr. Semmelweis wrote a thesis that the incidence of childbed fever was drastically cut down by the use of hand disinfection. At first, people thought he was insane, saying this is ridiculous. It is because bacteria had not been found yet at that time. With the advent of a discovery of bacteria, invention of the microscope, and the theory of Pasteur, people started believing that most diseases were caused by germs that came from somewhere. Dr. Pasteur disproved a theory of spontaneous germ generation, which was gradually accepted by people, leading to disinfection before treatment. The first antimicrobial agent in the world was salvarsan, a remedy for syphilis. This is Dr. Ehrlich. This is Dr. Sahachiro Hata. After the Meiji government was formed in 1868, many Japanese, including Dr. Hideo Noguchi and Dr. Kitasato, went to Germany to study bacteriology. In spite of brilliant achievements, neither Dr. Kitasato nor Dr. Hata received the Nobel Prize due to racial discrimination. However, owing to these people, a concept of disinfection of bacteria or virus for treatment was established for the first time in the world. However, this salvarsan is an arsenic. It can both sterilize and kill or impair patients. Then here's a famous story. When Dr. Fleming was making a culture of staphylococcus, molds on the surface of his bread fell on a dish and made colonies of molds. He found the area around the mold was bacteria-free, which was later identified as penicillin. The discovery of penicillin by coincidence was in 1928. It was thought that all infections on Earth would be eradicated. Penicillin at that time was a panacea. Nonetheless, in 1947, during the Korean War, penicillin, which U.S. soldiers always carry with them for just in case, turned out to be ineffective. This is an emergence of drug-resistant strains of bacteria. In fact, it took only 19 years from 1928 through 1947 for antibiotic-resistant bacteria to emerge in the world. MRSA, multiple drug-resistant bacteria, which are represented by Acinetobacter. They are completely antibiotic-resistant bacteria. We can say that the history of antimicrobial therapy is a fight against antibiotic-resistant bacteria. Even if a new drug is developed to kill bacteria, the drug will become ineffective, and then other new drugs have to be developed endlessly. The more they develop new drugs, the stronger the bacteria has become. This is literally a cat-and-mouse game. It has been less than 100 years since the discovery of penicillin in 1928, hasn't it? 100 years after that falls on 2028. It is 2015 now. It took only less than 90 years. We need to be careful not to make it happen. I myself am actually an advocate of antimicrobial therapy. To check antibacterial spectrum, perform microbial testing before selecting antibiotics. I also refer to a position paper, consider main effect and side effects, and also check a patient's health conditions by conducting test administration whenever necessary. I tell my patients that possible side effects are, and use the drug under strict control. Nonetheless, side effects or drug resistance do develop. To be honest, antimicrobial therapy is, if I may say, very difficult to perform. Even with physicians' help, troubles do occur. I wonder how we should cope with these issues. One issue related to infection treatment in Japan is not limited to dental areas. It also involves the medical area. First of all, infections are no longer carefully watched. Development of antibiotics has gone too far, and infections such as dengue fever in Japan have not been fully understood. Study of infection treatment is regarded as a declining area. The other issue is limitation of health insurance treatment. Limits are set to microbial tests, long-term drug administration, and co-administration. There is a territorial issue between dental and medical fields. Doctors can prescribe a drug for 3 months' use, while dentists cannot. For instance, tetracycline, an antibiotic, is very effective for the treatment of red complex. Dermatologists have no problem in prescribing tetracycline for acne for 6 months. On the other hand, we dentists may not be able to prescribe it even if they are not covered by insurance. Furthermore, I often face situations where a dermatologist, an otolaryngologist, and a dentist have been providing treatment to the same patient independently. I often recognize that my patient was prescribed Claris or Zithromax by other doctors. And lastly, an issue of drug-resistant bacteria. This is Matsui Hospital in Kodaira. Many patients with aspiration pneumonitis are admitted. Of the 280 patients, 3 died to aspiration pneumonitis. This should not have happened. How are they treated? If you have them lie down on bed, they are prone to aspiration, so you have them sit up like this. Patients with systemic illness are put under constant strain for a long time, and give them infusion continuously. What we dentists do is put a denture and train them to swallow, provide them oral myofunctional therapy, confirm if they are really doing well by listening swallowing sound with a stethoscope. After this treatment, etc., bedridden patients or patients who have been under constraint for 1 or 2 years would start eating properly or walking. Through these experiences, I am now confident that dentist status in the medical field is high. How can we treat these patients without using antibiotics? Firstly, we can treat them with local therapy by using periocline, etc. This is indeed a good idea. However, we cannot use periocline inside of the jawbone or in the lung. Secondly, we can perform a microbial test to choose proper drug product. This approach is also good. However, as I said earlier, we have problems such as a limit of health insurance or development of drug resistance after long-term use. It would be wonderful if we can provide antibacterial therapy with large amounts of antibiotics for long-term, just once in a lifetime, and never again. Administration of 4 to 6 weeks is a right method from a medical point of view, but is it a socially acceptable way? It has been said that medical and dental should collaborate. It is all bark and no bite. There are a few hospitals where medical and dental teams are working together. Is there a department that combines these various kinds of medical sections? Is a comprehensive medical treatment so easy? I have been using photodynamic therapy, however, it is not approved by the Health Ministry, MHLW. Then I have set out using probiotics method. What is probiotics? As I said, antibiotics cause side effects, develop drug resistance, and kill good germs. As if atomic bomb killed good and bad people altogether. Probiotics proactively increase good germs in our body first. This comes from a concept that illness is caused by a bad bacteria flora resulting from increased bad germs. In short, probiotics help maintain immune system by introducing good balance of germs into the gut. What are conditions for probiotic products? Bacteria therapy is useless if the drug is dissolved by gastric acid before reaching the gut. Good germs need to be increased. Microbial flora in the intestine needs to be improved. We need something that releases antibiotics-like substance to inhibit pathogens, that is safe to take as a medicine or a food such as yogurt or fermented food like natto, or reaching the gut. Good germs need to be increased. Considering these conditions, I decided to use probiotic products from BioGaia. L. reuteri is bacillus found in human breast milk. It can live and colonize inside of the mouth. It also produces antibiotics called reuteri. Reutterin inhibits the growth of some harmful gram-negative and gram-positive bacteria. Reutterin is said to improve human intestinal health and to have immunostimulatory action. What is its logic? We do not have much time. Lymphoid activation, like this, cytokine production, reduce infant and child mortality, cure autoimmune diseases. These have been reported and are expected. Colonization of good germs in the gut, prevention of NEC, sustains allergies, among other things. It is not mere existence in the gut. It has functions. Reducing crying time in colicky babies, decrease allergic dermatitis, immunostimulatory action in healthy human, good effects on breast milk, preventive effects against infection and cure perio, even decayed teeth. As if often the case, I was skeptical at first. There are lots of other things, so-and-so oxygenated water or such and such hydrogen water, and you name it. But I wondered, what if this is good? A pilot study. A patient with severe dental caries. These are the results of microbial tests conducted by BML Company. Pre-operative on the left, post-operative on the right. Take a look at this here. The number of mutants. The number of mutants. The patient took lozenges. Normal dose is 1 lozenge each morning during daytime and at night. But this is a food, basically, so we had them take 4 or 5 times more, just for 1 week. Take lozenges at 3 meals and snack times. The number of mutants decreased to 1/5 from 10,350, and Streptococcus down to half from 2.8 million. This is observed only in 1 patient, but the patient is a dental hygienist. She does brushing neatly, uses dental floss. She could not have managed better. She has in-depth knowledge in dental hygiene. As an employee at our hospital, she provides lectures on dental hygiene. Her cavity activities are high. Despite her proper management, cavity conditions were not good. However, only 1 week of taking lozenges made a big difference. Next, perio. We conducted the study in a patient who is likely to have perio. The number of T4 fiber decreased from 1,700 to 560. 1,700 denticola decreased from 340 to 14. This one is 1 week research too. Then I thought, why don't I conduct a larger epidemiology trial? In fact, I have been doing poster sessions until yesterday. Let me give you a brief reading. To be honest, I think antibiotic therapy is one of the useful therapies for eradicating causes. There are some issues such as developing drug resistance, treatment in pregnant or breastfeeding women. We are not sure if we can prescribe antibiotics or sedative drugs to a woman who has swollen gums, even though we do not know if she is pregnant or not. We have to consider counter-interactions when giving drugs to patients with severe systemic illness. It is not rare in this aging society. It is reported that people with dementia have 4 systemic diseases on average. Can we use antibiotics endlessly in the coming super-aging society full of dementia patients? I do not think so. As explained earlier, there is lots of evidence of this bacteria therapy. Having an immunostimulatory action, bacteria therapy may be applied in patients with systemic disease, including cancer patients. With this in mind as a prerequisite for research, we investigated how oral bacteria will change. In order to evaluate effects of probiotics, we did not apply SRP and TBI at all. As such, it is a very severe condition for probiotics. Total of 36 healthy male and female subjects with 20 or more teeth who have not taken ProDentis for at least 1 month, who are not taking antibiotics, etc. To begin with, we recruited 36 subjects under the same conditions usually applied for researches using probiotics. At their first visit, we conducted a periodontal tissue test, took an intraoral photograph and panoramic radiograph, and collected microbial sampling. On week 1 and week 3, in accordance with operative procedure we conducted a bacterial test using saliva, collecting first thing in the morning. This method allowed us to obtain results quite similar to a pocket test. Otherwise, as the range of diurnal variation of saliva is wide, there would be 100 times difference in the number of bacterial counts, as I already presented at Japanese Society of Periodontology. So, we decided to use a largest count as baseline. We asked the subject to collect bacterial sampling at the time of awakening at home. Later, they visited us for various evaluations. Using PCR invader method, we measured total counts of various germs including AA, PG, PI, red complex, BF, FN, TD. This is the research sequence. For 36 subjects, multiple 3 times of testing, thereby more than 100 times of microbial tests and pocket measurements. We had to spend lots of energy to do this, even though it was only for 3 weeks. As for breakdown of the subjects, the number of men was slightly higher. Average age is within a fairly small range. The research is not so biased. We also checked if they have systemic disease or if they smoke, etc. Patients' background will be presented later at an academic conference. Firstly, concerning total germ counts in saliva, there is no difference at baseline, week 1, and week 3. I will explain it later, but I think this is a really important point. If we use antibiotics, total germ count would become smaller because germ count will decrease. Secondly, about periodontal pockets, both data at week 1 and week 3 show significant results with these p-values. PG, TG, and TF also shows statistically significant decrease. Lastly, look at total bacteria count. Those numbers I showed are absolute number.
TF はこれは統計学的に優位に減りましたし
This is the point. As I said earlier, when we see periodontal disease, it is important to see how much infectious germs as opposed to normal inhabitants are present in the mouth. Take a look at this. PG, TF, TG, 3 red complexes all decreased by 5%, which is statistically significant. We can hardly achieve these statistically significant results without using antibiotics. On top of this, we provide neither brush training nor SRP. What does it mean by the fact that there is no statistical change in the total germ count? It means good germs increase, doesn't it? It is easy to kill all germs. All we have to do is use antibiotics. This is the benefit of probiotics. I'm sure, looking at the data, I thought, this is a wonderful method. Again, this is food, no side effects. One typical example is that redness of marginal gingiva in the low jaw decreased. Also, here are some narratives. My mouth feels fresh. I feel as if sticky saliva has become watery. Slimy teeth have become smoother. And this patient said the same thing as well, even though no brush training was given. If we provide brush training and SRP in parallel with probiotics, this would be a wonderful solution. I would like to move on to conclusion and consideration. I have presented improvement in periodontal pockets. The pockets became smaller, while total germ count remained the same level. Good germs increased and anaerobic bacteria count decreased without changing the total germ count. Though I did not describe this, I would like to add, when we talk about antibacterial therapy, the most common question is, the cost is not covered by health insurance, is it? Once again, this is a kind of food we can use simultaneously. This is highly likely to be one solution since we do not have to worry about the health insurance system. We can use probiotics in pregnant or nursing women instead of tetracycline, which are absolutely contraindicated. And there is one more. We can concomitantly use antibiotics in patients who have acute symptoms or have aggressive periodontal disease with a large amount of AA and PG germs. We can have them take lozenges, for instance, in parallel with periodontal treatment. There are various patterns available. Probiotic therapy is not a mere alternative to antibiotics therapy. I believe this is one of very useful options we can present to our patients. I was lucky enough to be able to get to know Dr. Asano. I understand that ADIG Corporation's vision is extend our healthy life expectancy with oral care. I strongly agree to this vision. Dental treatments, including us dentists, have made a great deal of contribution to improve QOL of our patients so far. But with this biotherapy, we can be more directly involved in lives. We can save bedridden people or those who are on the verge of death. I'm sure we have gotten a very useful key. We are obliged to do more. I strongly hope that these researches will be promoted by not only one individual like me, but also by research organizations, including universities. This will eventually improve dentist status. I would like to wrap up my presentation with this hope. Thank you very much. Dr. Yoshino, thank you very much. Now we would like to have a question and answer session. If you have questions, please proceed to the microphone. Thank you for the presentation, Dr. Yoshino. I am Dr. Takagawa from Hello Dental Clinic in Okayama. As you are already aware, we have maternity clinic on our property. I was fascinated with what you were talking about, co-administration to pregnant women. Would you please give us points to consider when we use? I know there will be no side effects, though. What I understand is that taking excessive amount is not good. Basically, there will be no problem. Unless, of course, a patient takes extremely large amounts of it, say 100 lozenges. These are culture of germs contained in breast milk. No problem with that. But just remember, this is a kind of snack. Take lozenges 6 times a day, including snack time, is okay, but more than that is not good. We may have data showing occurrences of diabetes, so make it this way. Tell patients to take lozenges at 3 meals plus 1 or 2 snack times. If you give lozenges to a patient who always has several snack times, the patient may end up eating 10 times or so. That's why we have to control the number of meals or ask them to eat lozenges instead of Frisk. That would be better. Thank you very much. Please go ahead. Thank you, Dr. Yoshino. I am Dr. Kobayashi from UI Clinic. I have a question for you. My patients often say to me, I am eating yogurt, which means I am taking lactobacillus. Will taking lozenges enhance effects or inhibit effects of yogurt? When they ask me, I don't know what to say. There are several kinds of lactobacillus, I think. I know some people are taking yogurt or other drug in order to improve their intestinal conditions. One of the good points of Rotary is that it exerts antibiotic-like functions. It kills bad germs without causing side effects. In that regard, this is totally different from other products. So maybe it would be helpful for your patients if you explained to them that there are a variety of kinds of intestinal germs. Lozenges work this way while others work that way. It is not a matter of choosing lozenges or yogurt. I would like to add this. To use probiotics for health maintenance or enhancement is a good idea. It is not necessarily a disease treatment. However, when we promote probiotics from a place of academic society, it would be better if we start as a treatment. This is what I like to think at this stage. Like I said, we can give probiotics to pregnant women. This can be a trump card, or some cannot take certain antibiotics due to liver impairment. Patients with renal impairment or liver impairment cannot take antibiotics. In short, we should start with treatment and then lead into health enhancement, etc. As a dentist, it would be better to use it for periodontal treatment at first. I personally think that way. Did I make myself understood? So, co-administration will cause no side effects, am I right? Absolutely. Different target. Thank you very much. Thank you. Yes, please go ahead. I am Dr. Morikawa from Keio. Thank you for the wonderful presentation. I have known probiotics just by name. Hearing your presentation, I am impressed with its effectiveness now. Especially, as you said, demands for oral care are high from patients from hematology section or cancer patients from other sections. Due to resource shortage and for other reasons, we have problems such as not being able to pull out a tooth right away or use antibiotics. I've come to realize that this method can be our strong or an option in the future. So I would like to discuss this with my colleagues from now on. My question is associated with previous questions, or even quite similar, but would you tell me if there are points to be considered? When using this to patients whose preoperative conditions are not good, who are under immunosuppressive conditions, such as patients before undergoing a bone marrow transplant or patients undergoing radiotherapy. I know this is a food, but this is exactly a point we should investigate on. According to literatures, our research results from overseas companies, probiotics are good for these patients. However, we have different dietary life. Climate differs too. For instance, people in East Asian regions consume a large amount of capsicum, or big meat eaters have different gut conditions when compared with ours. In fact, I have already made a plan to set out a study. The hospital where I manage as a board of director has 280 patients. Some have no teeth, and others have underlying disease suffering from diarrhea or constipation. What I'm going to do is have them take lozenges and collect bacteria samples from their stool. I guess it would not be so hard to obtain samples. On the other hand, asking outpatients to give their stool to us would not be possible. Can we do that from admitted patients? Some patients with systemic diseases wear a diaper. I think I'm going to start from something from here. Yes, I agree with you. Particularly patients with oral cancer cannot be provided with oral care per se. So probiotic therapy would be an excellent method to treat them in the future. So please, let's embark on a research in cross-sectional manner. I believe this is a wonderful opportunity for us to raise the status of dentists. We can treat patients who have systemic illness because of that. Frankly speaking, what we do is oral care and at the most swallowing, eating, and tongue function training. If we can have a trump card to strengthen the immune system, this will be a very important option for dentists. There are plenty of things to be clarified. So I hope we can strive in collaboration with industries and academia, as well as in collaboration with clinics and hospitals. Thank you very much. Please. Thank you for the enthusiastic presentation. I am Dr. Nida from Tokyo Medical and Dental University. Do you think lozenges give effects on bacterial flora in the gut, which then lead to impact on bacterial flora in the mouth? Or does it work directly to flora in the mouth? I have got confused because I have heard that lozenges is effective in patients with systemic disease, such as a cancer, other than oral one. Would you please streamline it? Indeed, this is difficult. We can say that bacteria exists in the mouth because there is evidence of colonization in the mouth. However, it seems they reach other parts of our body too. That's why we need to do more research on things including this point. I cannot perform PCR on rotary. If I could, I should culture the bacteria to evaluate how much of them decreased at several hour intervals. There is no other way. I am just an owner of a clinic, and it is difficult for me to culture bacteria. If we can work together and obtain good data, we can promote it. It would be wonderful if the status of the dentist rises. Also, it would be really desirable if we can enhance bacterial flora in the intestine. I believe you know Dr. Chie Hayashi. She is one of the best contributors to do this research. She happened to have diarrhea. She also took lozenges while doing the research. It actually worked for her. This is a bonus. This episode has convinced me that it actually works in our whole body. I would like to investigate on this point as well. If lozenges has medical and dental effects, will it be an issue? Like, which area should it be in? It may be hard to organize it. Exactly. Let me give you an example. In the U.S., smoking cessation therapy is given by a dentist in many cases. The therapy leads to the prevention of systemic diseases, which in turn make the status of dentists higher there, I suppose. Prevention of a periodontal disease will enhance the oral immune system, which eventually bring about the improvement of conditions of patients with autoimmune disease. This is absolutely wonderful. Then people will first visit dentists to consult with. If we change the course into this, let me repeat once again, it would be the best method for us to be able to raise our status. Thank you very much. With this question, please join us and give us a big round of applause for Dr. Yoshino. Dr. Yoshino, thank you very much.